Good morning. I'm Matt Trabalski with the Community Access to Recovery Services.
Good morning. I'm Patricia Gutierrez, and I'm the Alcohol and Drug Abuse Program Service Director at Impact.
This morning we're going to be talking about the principles of good clinical assessment using the CARS Comprehensive Assessment. Next slide, please. The CARS Comprehensive Assessment is a semi-structured clinical interview, and what that means is that there are a list of questions that need to be asked, and there is certain data that we are collecting. There is a format, there is a certain structure to it. However, it is semi-structured, which means that the interview is really to be conducted in a conversational, kind of open-ended way that allows for back and forth amongst the different questions and the different assessment domains. It's really meant to be a conversation, an informal conversation between you and the client with whom you're doing the assessment. And what we're really trying to do with the CARS Comprehensive Assessment, and this is a difficult balance, but it's one that's a balance that needs to be struck between any semi-structured interview, is a balance between allowing the client to tell his or her story and to collect the data necessary for good clinical placements in the appropriate levels of care, to do risk adjustment, to track outcomes for the clients that we serve, to make sure that we're providing the best care possible. And while this balance may seem to be somewhat daunting for many of us who haven't done this before, let me provide you some reassurance that it is possible. I wonder, Pat, if you could speak a little bit more about this.
Sure. Thank you, Matt. It is very possible to strike the balance between getting the information you need and building that rapport with the client, making the client feel welcome, making the client feel safe within your office. In the beginning, it's a balancing act. But as you do more assessments and you become more familiar with it, it will happen. It becomes a natural for you and the client.
Absolutely. Next slide, please. And to piggyback off something that Pat said, familiarity with the comprehensive assessment, with any assessment, makes for a better, more conversational, more warm and inviting clinical interview. Familiarity, 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 practice, practice, practice. The more that you do it, the more familiar you are with the domains of the assessment, with the questions on the assessment, and even more importantly, with the intent behind the questions. Specifically, what types of data are we attempting to glean from the client? The more effective you will be, because the less tethered you'll be to the actual assessment itself. You won't have to read it off like a robot, words off the screen or words off a page. You can make more eye contact with the client, be more attentive and engaged with the client, because you know in the back of your head the types of information you are attempting to cull from the conversation. So practice, practice, practice. And I think, Pat, you have a lot of experience giving thousands of these assessments. I wonder if you want to speak about that.
Correct. I've done thousands over the year of the assessments, and it is true. In the beginning, it's going to take you a longer amount of time because you want to make sure you hit every question, you want to make sure you ask every question and you answer it. Over time, though, these questions become such second nature to you that you'll be able to just sit down and have a conversation with the client and be able to pull out what the questions are, and it'll take you less and less time. We've gone from probably in the beginning like a 2.5-hour assessment. By the time a year into it, you're down to hour, 45 minutes, depending on the information that the client has, and if there's a lot of different drug use or different mental health situations that you need to document. But most of the time, if you practice and know your questions, you do not need to just always be looking at the paper. You can have the eye contact with the client, which is very important to build that rapport, to get the client feeling relaxed and at ease so that they'll be able to answer the questions.
Absolutely. Next slide, please. One of the tools that we here in the CARS division use to place clients in the appropriate level of care is the American Society of Addiction Medicine patient placement criteria. And these are ratings of severity and need in different life domains for the client. And you derive those ratings by completing the CARS Comprehensive Assessment, which collects a tremendous amount of excellent data that allows you to then make these severity ratings. One of the tools that is built into the CARS Comprehensive Assessment is the Addiction Severity Index, and that's something that Pat has extensive familiarity with and something she was referencing earlier. But there are a number of other assessments that are built into it. And this is an example from some previous research looking at the administration time of the different assessment instruments and the length of time that it took to complete the assessment instruments to actually make the ASAM placements. And as you can see, over time, the length of time to complete the assessment battery actually drops over multiple administrations. But even within the first 20 to 40 administrations, you can see roughly a 15% drop in the time that it takes, which is significant when you think about how crunched our clinical time is and how we oftentimes have something scheduled hour after hour. So there is a practice effect here. We can go faster as we practice this. So it's not only helpful to build rapport, but it also increases the rapidity with which you complete the assessment, which creates more time for you as a clinician. Next slide, please. So, Pat mentioned this earlier. Building rapport is key. Clinicians achieve successful clinical interviews not so much by what they do or say, but by making sure they express the proper attitude. And that attitude that you bring to the clinical interview is key. It is possible to build rapport. It is possible to build a therapeutic alliance with your client during a clinical interview, even if you'll never see that client again. And the essential elements of the interviewing relationship, for those of you who are clinicians who have gone through counseling classes and things like that, these will be very familiar to you. These are the successful elements of a good therapeutic relationship as well. Sincerity, warmth, unconditional positive regard and acceptance, understanding of the client, expressing a genuine interest in their issues, positive regard, as I mentioned earlier, and a strength-based approach to clinical assessment. And we're going to talk about a strength-based approach and highlighting strengths throughout the clinical interview, throughout the rest of this PowerPoint, really. That's going to be something that's going to be sort of an overarching theme here. So it's your philosophy of human growth and change which sets the tone for the entire interview. So, Pat, I don't know if there's anything you want to say about this?
I did, and I'd like to give you an example of
Sure.
building rapport within the first couple hours. You figure you're only with the client for 2 hours. How can you build rapport? It is very possible. We have clients that when we do our assessment, we see the clients for an hour and a half to 2 hours. We have clients that call back 3 or 4 months later after they've completed one round of treatment, they're going into an aftercare program, calling us back saying thank you. Thank you for spending that time with me and listening to me and just being able to let me talk to you. That's what started the whole process. If we can make them feel comfortable and welcome and accepted at the front door when they first come in, it'll hugely increase their probability of completing treatment.
Absolutely, and I think that's an excellent point, Pat, is that really when you are completing this assessment, for many of our folks, this is their introduction to treatment that may be years later on in their life, that they may be in treatment for 5, 10, 15, 20 years down the road. And this is their front door. This is their initial experience, and we have the opportunity here to make that a negative experience or a positive experience. And we really want to make sure that when people come in, that it's as positive an experience as possible, because that can set the tone for the rest of their treatment tenure. Next slide, please. So this is a quote out of a book by a man named Gary Groth-Marnot, who has written extensively about good principles of psychological assessment, and his handbook of psychological assessment is kind of a pillar in the field. He talks about patient ratings of the quality of interviews have been found to be dependent on the extent to which interviewers can understand the patient's emotions and detect emotional messages that are only partially expressed. Essentially, do you have the ability to empathize with the individuals by not only attending to what they say, but what they're feeling and what their nonverbals are? And that really, what you're talking about there is accurate empathy, which is, again, one of the core principles of a good therapeutic counseling relationship. So, and as we mentioned earlier, the less tethered you are to the specific questions of the CARS comprehensive assessment because of your practice, because of your familiarity, the more attendant you'll be able to be to the individual sitting in front of you. And again, you're building rapport this entire time. The quality of the entire interview is based off a good therapeutic relationship with the individual who's come in for services. Next slide, please. What may not be surprising to many of you, we've already talked about some of these things, and we're going to see these again and again and again, is that the principles of motivational interviewing can undergird the quality, a quality assessment process throughout. And we're going to be highlighting these principles of motivational interviewing throughout the rest of the presentation, the PowerPoint here, because you're going to see them come up again and again. You're going to see principles like the expression of empathy, and accurate empathy, right? Which is the slide that I was just talking about before. The ability to really understand what your client is going through. The ability to roll with resistance. Not everybody who comes into treatment really wants to be there. Not everybody is going to be buying the car that we're trying to sell them. And the ability to be able to work with that individual and not get caught up in arguing with them. That sets off the interview on the wrong foot almost immediately. The ability to develop discrepancy, the ability to take data that the client is sharing, but also understand what the client wants to do. What are his goals and values? And those are things that are going to come out over the course of treatment. You're not going to know all of those things at the assessment when you're doing the assessment, but some of them you will know. Some of these are things that you can be the initial starting point for beginning to develop some of that discrepancy. So between what the client wants to do and where they're at right now. And then supporting self-efficacy. As I mentioned before, having a strength-based approach to this entire process is key. And Pat, is there anything you want to say about this?
Yes, and we'll get into it more when we go through the principles, but one of the principles later on will be letting the client, when they come in, they're at a certain stage level, and let them be at that stage level. It's, to argue with the client, to tell them, no, I'm the clinician, I know what you need, is not a correct way to do that. Even though as a clinician you may think, okay, this client needs to go inpatient. If the client wants outpatient, let them start with outpatient, because at least they're starting. You're letting the client have a choice in their own treatment, which is very important if you want them, to continue on. If they feel like they're being bullied or pushed into it, or, oh yeah, you're the expert and I'm not, for them likely to go on and even attend the first appointment, your chances are going to decrease. So these are very important points to keep in mind.
Next slide, please. All right. We have 14 basic principles of good clinical interviewing, and I'm going to briefly read through these, and then we're going to talk about each one in more detail through the rest of the PowerPoint. The first is set the stage, creating a comfortable room. The next principle, setting the stage part 2, bringing the client to the room. These are things that are very critical, as you'll see soon. Discussing informed consent, confidentiality, length and purpose of the interview, giving clients the right to decline to answer. Allowing people time to elaborate and acknowledge and validate what they're sharing. Pulling data out of the client's narrative. Parenthetically, it's okay to jump around. Clarifying ambiguous data. Taking opportunities to express or to utilize previously expressed information to demonstrate you are paying attention to the client. Very important for building rapport. Be sensitive to trauma issues. Be sensitive to cultural issues. Point out client strengths and look for opportunities to reinforce them during the interview. Use increased problem awareness to build motivation. Redirecting the talkative client, engaging the withdrawn client, engaging clients who are in distress. Noting nonverbal behaviors, mental status exam during the interview, and meet the client where he or she is at. Next slide, please. So principle 1 is setting the stage before the client even arrives. And I talked about a comfortable room, but Pat also mentioned when she and I were talking about this Kleenex, which I'm wondering if you can talk a little bit more about this particular principle.
Correct. Sometimes when clients come into the room and they're going through the assessment, they start crying. This is a very emotional time for them. Some of them feel, really bad about themselves and all that, so they start to cry. The worst thing to do is to take a box of Kleenex and hand it to the client, because then it's almost telling them, stop crying. Here's a Kleenex, wipe your tears. I always have a box of Kleenex at the end of the desk, and if they choose to take it, they choose to take it. If they choose to let the tears run, you let the tears run. This is the client telling their story. They need to do it in their way. You also need to make sure that your room is comfortable. Sometimes you have to have a desk in between you. If it's possible not to have a desk, that's be better, because that's a barrier. But if you have to have the desk, that's understandable, because sometimes you need the computer to type this in. But then, having a comfortable chair, because this is going to be an hour and a half, 2-hour assessment. You don't want a plastic hard chair. Make sure that the chair, is comfortable. If you want arms on it, if you don't want arms on it, and then make sure it's positioned right, so that you can have eyesight to the client, and that the computer is not in the way or anything like that, and have everything available for the client. Like if they need a pen, have a pen there. Have everything on your desk so you're not fumbling around later.
And it sounds like, if I'm understanding correctly, Pat, that a lot of this is things that you do to set up the room before the client even gets there, so that when they come in, you're not rearranging things, that you're thoughtful about how you position the room in the most client-centered way before they even arrive.
Correct. It's very important to have that done, because as soon as they walk into the room, a client can tell from how things are placed in the room, actually what kind of person you are and what kind of assessment this is going to be.
Sets the tone. Right.
Thanks.
Next slide, please. Setting the stage, bringing the client back to the room. Now notice we haven't even started talking about the actual clinical assessment yet, and that is because the clinical assessment starts as soon as the individual walks in the front door of our offices. As soon as we bring them back to the room, all of the assessment is occurring. You as a clinician certainly are engaging in your own mental status exam, even in an informal way, about the client when you are going back to get them. But they're also evaluating you. They're evaluating the services in terms of, like, is this a warm and inviting place? Does the individual who came and got me seem friendly? So the evaluation begins as soon as they walk in our front door, probably even before that, but when they're calling in. But, it's only so far you can go back upriver. But so I wonder if you could talk a little bit more about bringing the client back to the room, Pat.
Sure. It's always more, I guess, appropriate. If they're waiting in the waiting room, we always just go in and call them by their first name. It makes it less standardized, less official. If you call them by their last name, Mr. Smith. And so if you call them by their first name, Joe, Fred, hi, and introduce yourself. My name is Pat, and I'm going to be doing your assessment today. And then when you walk them back to your office, I see a lot of clinicians walking ahead of the client, and the client is following. That's showing a superior positioning, that I'm walking first, you follow me, I'm more superior. It's better to walk with the client or guide the client. What I do is, if I'm taking a client back, I offer him, you first, and walk with them down the hallway and making small talk. Is it raining out today? Or, how warm is it? Is it chilly? Whatever the weather is outside, that's easy small talk right away. And then if you have to go through any doors, I always open the doors for the client and let the client go through. They usually automatically on the other side stop and wait for me to come through after them, and then offer them a chair in the office. Just, don't say, oh, here, walk in. Say, here, you can have a seat here, thank you, and offer with your hand gestures. It makes it feel more comfortable. It makes the client feel that they're cared about, that they're just not, hey, you come out of the waiting area and come and see me.
And I wonder, what's interesting about that to me, Pat, is that that same kind of idea of taking a one-down position is something that I was taught when I was in graduate school a million years ago, that really you want the client to feel like an equal, but even more so that they're expert of their own life.
Correct.
And I think that that's something that, is, again, much like the strengths-based component is an overarching theme throughout this process, is that the same basic principles that make for a good counseling relationship will also make for a good assessment relationship, a good clinical assessment relationship. I wonder if you could speak a little bit about how to handle it when collaterals are attending the interview and want to attend the interview with the client. What then, how do you handle that?
Many clients come with family members or concerned friends that want to go into the assessment and want to make sure that the client is getting what their needs are met. This is ultimately up to the client. So what I will tell the collateral, if they're in the waiting room, I'll say, let me take, John, Joe back to my office and let me talk with them. There'll need to be a release of information signed. And then, let me talk with them a little bit and then I'll come back up and get you. When I take the client back, I'll talk with the client, do you want the person in? Do you want the person in for just part of it, all of it, not at all? It's totally up to you. And if they want them in, we'll sign a release. I'll go and I'll get the family member or friend, and I will do the same thing down the hallway, walk with them, not in front of them. And then if the client does not want the family member, and then I'll just go back out to the lobby and say, the assessment's going to take about an hour and a half to 2 hours. If you'd like to go and get some coffee and come back later, that would be fine.
Yeah. And I appreciate that, because then also what you're doing, again, before you even start the interview, is you're letting the client kind of drive it. It's a client-centered approach, that the client gets to say who should be involved in their care. And that starts at the front door.
Correct.
So, yeah. Next slide, please. Principle 3, informed consent, confidentiality, discussing the length and purpose of the interview, and giving clients the right to decline to answer.
Once you bring the client back into your office and you find out if they want their collateral in or not, you need to explain what the assessment is. Sometimes clients may come to the office thinking they're looking for one thing and it's really another thing. So it's good to explain, first of all, what the assessment is. Explain how long it's going to take. Sometimes clients think that this assessment can be done in a half an hour and they have another appointment with the doctor, or they need to pick up their children from school. So give them an average time, an hour and a half to 2 hours. And then you need to explain what confidentiality means and how important it is. You need to explain to them that unless you sign a release of information, the confidentiality, nothing is going to leave this office. We have to do an assessment, and we have to put it in on a computer. So that's where the informed consent comes in, and you need to explain to them, this informed consent is what you're allowing us to do the assessment for you. You're allowing us to enter this information on the computer and come up with a recommendation for you at the end of the assessment. You're allowing us to put this in the computer, knowing that Milwaukee County or another someone else in behavioral health or another treatment agency will be able to see it once you sign the release of information. But this information is in on the computer, and you need to make sure that your client knows that it's in on there. Another point is that let the client know that this is a long assessment, an hour and a half to 2 hours. If they need to take a break to go to the restroom or to just get a drink of water, let them know that that's okay. At any time, if you say, wait a minute, I need a second, or can I just go to the restroom, that is fine. Make sure you know, obviously, where your restrooms are and where there's water available for the client. But this is long, and some of them, come in and they're anxious and they may not have had anything to drink in the morning, or they may have drank a bunch of coffee to try to settle their nerves down or whatever. So make sure that they can do that. And also give them the permission. Some of the questions on the assessment are pretty personal. And sometimes they do not feel comfortable answering them. And they need to know that they have a right not to answer. So let them know. It's okay. If you do not want to answer a question, that is perfectly fine. That is perfectly okay. We're not going to make you leave. It's not going to, make your recommendations higher because you don't want to answer this question. I just need to hear from you that I don't want to answer this, and I can put that down, and that may be something that you can go on and talk to your counselor with later. So always giving the client permission. This is their assessment. This is their interview. They need to be able to run what they need. And I know it's kind of hard. You don't want to stop the interview. Sometimes you're on a roll and you're getting what you need. But if that client needs to go to the restroom, you need to let them go. We are going to have an example of this right now. Hi, Fred. My name is Pat, and I want to thank you for coming in today. I'm going to tell you a little bit about the assessment. The assessment we're going to do today is going to take about an hour and a half or 2 hours. I'm going to be asking you a lot of questions. Some of the questions might seem repeated, and I'm sorry about that. I'm just trying to get as much information as I can so we can see how we can help you. First I wanted to tell you about the informed consent. You're going to need to sign some paperwork. I have a pen here for you. What this is the informed consent, and what it states is that you're giving us permission to enter your answers into our computer system so that we can make a file on you. So we have documentation that you were here. By signing this, you're giving us permission that we'll be able to put it in. But I also want you to know if there is any questions that you do not want to answer, that you feel I just can't answer at this time, all you have to do is just let me know. It doesn't change the recommendations. It doesn't look bad or good or anything for your thing. You just, if you're uncomfortable, just let me know, and that's fine. Okay.
Why do you need a file on me?
It's so that we can keep a record that you were here, so that if we need to let your clinician know, they'll be able to see the notes, so that they maybe don't have to ask some of the same questions with you. Or if, like, in a year or two you come back in to see us, we'll have your last file, so we'll know some of the history already on you. Again, if there's any questions that you don't want to answer, just let me know. Okay. Also, if you need a break at any time, you just let me know. The restrooms are outside around the corner. There is a bubbler or water fountain around the corner. So if at any time you need a break and you want to leave, you need to take care of yourself, please just let me know. We can stop at any time you want. So this is going to give me permission to do this, and I just need to have you sign this. Also, I do know that your mom was waiting in the waiting area, and she sort of wanted to come back. Now, it's totally up to you if you want her to come back now, if you want her to come back at all.
No.
Okay.
No.
What I'm going to do is I'm going to go then and let her know that it's going to take about an hour and a half, so that she can go and get some coffee and then I'll come back and it'll just be you and I with the assessment. Is that okay?
She thinks she needs to run my life for me.
Okay.
I don't need her doing everything for me. I am a grown man, 37 years old. I don't know why she does this.
Okay.
So,
so we have this informed consent. Later on, I'll be getting a release of information if we find a treatment agency is needed. So, but I'm going to take this paperwork now, and then I am going to go and let your mom know that it's going to take about an hour and a half to 2 hours. You're going to be with me, so she can go and get coffee. Is there anything I can get for you? A cup of water or anything?
I'm pretty thirsty.
Okay, I'll get you some water then.
That'd be great.
Okay.
That'd be great.
Alrighty, let me go and tell her, and I'll be right back then. Okay?
Okay. Principle 4, allow people time to elaborate and acknowledge and validate what they share. And I think that this is a principle that is extremely important to highlight. They're all important, but one thing that is extremely valuable about this one is that, again, as I mentioned at the very beginning of this presentation, I think the perception oftentimes, Pat, is that people believe that when you're doing a structured interview or a semi-structured interview, that all you're really doing is reading questions off a page. And that may be the case if you're doing like a skid for the psychiatric diagnoses. It's a structured interview, but a semi-structured interview really shouldn't be just simply reading questions off the page like a robot. And I think that that's a common misperception, and one that I hope we will disabuse here. So.
Correct. It's not, you don't want to sit down and start just checking off, oh, yes, no. You want to let the client tell their story, and that is one of the points in here. Let them explain it in their way. That's how you're going to get the best information. if you are asking the questions and you're asking closed questions, you're going to get yes or no answers. But if you let them tell their story, you're going to get an abundance of information, usually more information than what you actually need to complete the assessment, but a lot of information that you can put down in the comments sections, so when their counselor receives this assessment, they have a wealth of knowledge behind them. Use your active listening skills once you're there with the client. You'll see some clinicians will lay back, cross their legs, and how can I help you? I mean, that's not active listening. Active listening is when the client is talking, you're nodding, you're validating what they're saying. They may even stop for a second, and you're like, okay, wow, that was a lot that you went through. Tell me more. Do you want to talk more about this? So it's use your active listening skills. Eye contact. Eye contact is very important. In the beginning, I always ask, can I take notes for this? Because I always blame it on, I'm a little older than you. I may forget something. I may forget something important, but I want to make sure I get your story down. So is it all right if I take notes? So my eye contact may not be complete and may not be steady, but really I want to get everything down so that I don't make a mistake and that I get your story down. So I ask to take notes. Anything you'd like to add with that?
No, I think that's very valuable, and I think that again it goes back to this idea of the basic principles of good clinical assessment skills. Are also the same principles that underlie good counseling skills. I mean, those active listening skills, I remember learning those, like I said, when I was initially in graduate school. That those are the things that we do to make sure that people feel heard, empathized with, validated. Those are going to be important regardless of whether or not you meet with the client once for 2 hours for a clinical interview or whether you have an ongoing therapy relationship with them.
Correct. And with the nodding, sometimes clients come in and they are telling you their story, their way, and it's really not making sense to you. But the acknowledging and the answering, okay, that's a way of letting them know that you're listening to them. And if you need to get different information about the story to really get the correct information, you can always do that later as you're talking with the client. So just let them tell the story and use those active listening skills. And we are going to show you an example of this right now. Okay, Fred, I went and you have your water. I've told your mom to be back in about an hour and a half. Now I'm going to...
Was she pissed?
No, she was fine with it. She said, okay. She just wants to make sure that you're comfortable, so I think that was really good. Okay? I'm going to ask you now some questions, but I want to ask you why you're here, but I need to ask you if it's okay if I take notes. I like to make sure that I get a lot of the information down, and sometimes I forget stuff, and I don't want to really forget important stuff that's to you. So is it all right if I take notes during this? I can let you see the notes later if you'd like. It's all going to be just little words, so that later on I can go back and remember what you said. That help me remember.
What are you going to do with it after you're done?
Well, this is what's going to go into your assessment, and then after this is done, I will shred it all. I don't keep these notes, but these notes are going to help me put the information into the system. Okay, and I'm also going to need to put my glasses on because I have to read with my glasses. Okay, so. Alrighty, so, Fred, tell me why you came in today. Why are you here?
Honestly, I'm not really sure. I was in PCS about a week ago. And the clinician that I saw there, the doc, said I should get more assessment because he thought I should get something called, I don't remember what it was, care management, case management, something like that. He said he thought that would be helpful.
Okay.
So I don't know. I'm not sure. I'm not really the one with the problem. It's not my roommate is an asshole, and I think he's always on my case. He's always messing with my stuff. He doesn't respect my space. He's a slob. Just stresses me out. What I really need is an apartment. I need my own place. I don't understand why I need case management or whatever that is.
Okay.
So my roommate's the problem, not me. So I don't know why I'm here. It pisses me off, honestly, a little bit.
Okay.
But I don't know. Can you get me an apartment?
Well, let's go through the whole assessment and see. I'm not sure exactly, what services we can get to you for you, but let's answer the questions and let's get to the end with it, and then we can work on that together to find out exactly what needs need to be met and what we need to get for you. Okay?
Okay.
Is there anything else that you wanted to tell me about the roommate or how he's stressing you out?
He's just a slob. I'm just always picking up after him. He never leaves my stuff alone. I think he steals from me. He just, he's got a drinking problem. There's always a case in the fridge. I don't, he won't leave me alone, and I just don't. I just need my own space. I feel like I'm getting choked there.
Okay.
I need my own space.
Okay, I can totally understand that. What do you do to calm yourself down when you get into situations like this?
I watch TV.
Okay.
When he's not in the room, because we have one TV. It's in the main room, so I can't even. Sometimes I go to my room and listen to music. I take a walk and smoke a cigarette.
Okay.
Sometimes I have a beer or two.
Sometimes a beer, okay. I'm sorry, is that a beer or two?
Yeah.
Okay, okay. So you like listening to music?
I do.
Okay, what type of music?
Usually punk rock.
Punk rock, okay. All right. Is there anything else that you think that I need to know up front before we start in on these questions? Now, these are pretty extensive questions, and there's a lot of them. Again, I apologize, but we're just trying to get the best assessment we can to determine what we can help you with, okay?
As long as there's an apartment at the end of the rainbow, let's get it to it.
Okay. All righty.
Principle 5, pulling the data out of the client's narrative. And I think this can be very challenging for individuals who are either used to just doing a completely open-ended clinical interview that doesn't have a set of questions that need to be answered, or who are used to doing a highly structured clinical interview, again, such as like a SCID or a SCID-2 that you would use to derive DSM diagnoses, where you're not allowing the client to really elaborate on anything. You just provide question after question, and it's much more regimented. I think this is a very difficult thing for people to do initially, but I do believe that, again, going back to something that we talked about very early on in the presentation, that the more familiar you are with the domains and the questions and the intent behind the questions, the easier it is to pull the data out, because you will hear things being expressed that speak to one of the questions on the assessment. And I know that that's something that we mentioned earlier, but I don't know if you want to say something about that, Pat.
It is as the client is telling their story, and as you get to know the assessment and the questions in it, they will give you, like I said before, a wealth of knowledge, and they will answer questions that maybe in section 6 is like the employment. They may tell you that up front, or, I lost my job. I had my job for 6 years. I started using, and, I was working with machines, and I said I couldn't work with machines anymore. You already have that in the last 3 years. What was your occupation? You were working with machines, and you were working full time. You already have that question answered. Not that when you get to that section, you don't, just go over it again, but they will tell you a lot of questions in different sections, and it's okay to like put a star by it, because you know that you'll be coming back to that when it comes to that section. So as we talked about earlier, as you get to know the assessment more and the questions that are in it, you'll be able to pick out what you need into what section.
And I think it's important also to highlight that it's okay to jump around. That if you're talking with a client about their drinking, for example, and they talk about the fact that they believe that they self-medicate, they use drinking to self-medicate because they're severely depressed. And they start talking about how depressed they are, and they start talking about all the psychiatric issues that they have. There's nothing to stop you from moving over to the mental health section of the CARS comprehensive assessment and just starting to complete that and answer as many questions as you can, or just complete the whole section if the client is talking about that, and that seems to be where the flow of the conversation is going. So the assessment needs to be completed, not all in one sitting, and not all in the same order. This doesn't have to be sequential. The flexibility of a semi-structured interview is such that it should allow you to fill in the data where the client is going, and then go back and sort of plug the gaps later. So.
Correct. And Matt, you brought up a good point, and I know we'll get it a little bit later in one of the other principles, is that if a client starts an assessment and the information they're telling you is just way too overwhelming, or they just can't sit through the assessment, they're having some anxiety or anything, it is okay to stop the assessment and have the client come back another day, have the client come back in a couple hours, reschedule the client when it's appropriate, or when the client can make it. It's okay to stop in the middle of the assessment. You don't have to do this all the way through.
Right. And I think that speaks to being client-centered in our approach to the assessment. Somebody is not going to feel cared about if they're in severe distress, and we look at them and say, well, come on, we got to keep going forward here.
Right.
If we can say, do we need to take a break? Do we need to do this another day? I think that shows people that first and foremost we care about them and how they're doing.
Correct.
So, all right, next slide, please. Principle 6, clarifying ambiguous data. And I think that this is, again, another challenging thing to do, but there are some tips and tricks to be able to help us do that. And I wonder if you'd like to elaborate on some of those, Pat.
There are. When clients come in, sometimes they're not the best historian. They may say, and the questions are in the last 13 months to 3 years, in the last 30 days, and sometimes they're not, they can't remember for various reasons, whether it's their drug use or their mental health issues. So a lot of times we need to play the scaling game. We call it, if a client says, well, I've been in the emergency room. How many times have you been in the emergency room in the last, 13 months to 3 years? And they'll say, I don't know, many times. Okay, is it more than 5? Oh yeah, it's more than 5. Okay, is it more than 10? Oh yeah, more than 10. Is it more than 15? No, not 15. Okay, is it more closer to 10? Yeah, I think it may be around 11 or 12. Okay, 11 or 12. And then ask them, what would you like for me to put down? Because remember, this is their record. So I always ask them, would you like for me to put 11 or 12? Put 12 down. Okay, I'm going to put that you were in the emergency room from the last 13 months to 3 years 12 times. And I clarify that, and then they'll say, well, no, make it 12. I'll change it to 12, and I'll repeat the question again. So you've been in the emergency room in the last 13 months to 3 years 12 times. Yes, okay, correct, thanks. And so we just go back and forth like that until we can narrow them down to a close enough time. We don't want to say, okay, more than 5, let's just put down 15. You know, we want to try to get as close as the actual number as possible, because this is very important information that clinicians will be using for, you know, in their files. So
Absolutely. Yeah, and with some of these things, we are going to have, the clients are going to have to guesstimate, but there are ways for us to increase the accuracy of that guesstimation, for lack of a better word. I also think one of the things that's important to highlight in this process is that we have the questions with, you know, that have answers that we need to obtain, but just because we have the question doesn't mean we can't ask probing questions or clarify what those questions mean, because really at the end of the day, what we want to do is get the data that speaks to the true intent of the question. And if the client doesn't understand something about the way that we're asking it, it doesn't make sense to them for whatever reason, you know, it's our job to make sure that they do get it.
Correct.
You know, and we're not, again, I've used this term before, we're not tethered to the specific question. We can ask the question, but if they don't understand it, we can go beyond that to make sure that we explain it well enough so that even a client who, for example, may be illiterate will be able to answer it in such a way, and we know that the data that that client provides is with the same understanding of the intent of that question as a client who, you know, reads fully well. So the two clients who may come from very different backgrounds are both answering the same question.
correct.
Yeah.
And we'll be showing you an example of this next. Okay, thanks, Fred, for answering those other questions. We're going to start on questions with regards to inpatient and outpatient with regards to mental health. And I'm going to ask you the same questions, but they're going to be for different time periods. Like, have you been in an inpatient mental health hospital in the last 30 days?
No.
Okay.
No, not in the last 30
Okay.
days.
How about in the last year?
Yeah. I was at BHD once a couple months ago, and I went to St. Luke's South Shore. I don't know. Yeah, it was probably back in April or May or March or sometime in the spring.
Okay. So that would be 2 times in the last year then?
2
Okay.
times.
I just
Yeah.
want to
Okay.
make sure. Okay.
Sure.
How about in the last 13 months to 3 years?
Yeah. I have.
Okay.
I don't know.
Okay.
Yeah. I'm not sure. A few times. I
Okay.
don't remember how many.
Do you think it was more than 5?
No.
No.
No,
Okay.
it
So it was less than 5.
Yeah.
Okay.
Yeah.
Do you think it was more than 2?
Yeah.
Okay.
Yeah.
Do you think it was 3?
It's 3 or 4.
Okay. 3 or 4 times?
Yeah.
Okay. So with regards to this answer, which would you like for me to put down?
I think it was closer to 4.
4?
Yeah.
Okay.
Yeah.
All right. I will put
Yeah.
4 down. Okay. And so in your lifetime, how many times have you been inpatient in a mental health hospital?
Boy, including the ones I just mentioned?
Yes.
Boy, a lot.
Okay. Well, we know that from the past 30 days you weren't in, but you were in 2 times, so that's 2, and then the 4 for the last 3 years. So that makes 6. Okay, so we know it's already 6. Now, in your lifetime, do you think it was more than 10?
Yeah.
Okay. How about more than 15?
Maybe not more than 15, but
Okay.
probably at least 15, 14 or 15.
14, 15?
Yeah.
Was it more than 12, you think?
Yeah.
Okay. So you're hovering around 14 or 15.
I'd say 15.
Okay.
It's been a lot. Yeah.
Okay, so 15, I can put 15 down here?
Yeah.
Okay.
Boy, that's a lot. Never counted them up before.
Never counted them before? Never looked at it like that before? Huh? Okay.
No. 15 times. Jeez.
No, that's all right. That's okay. What's important is that you're here now, and we'll get this. Sometimes people have a high number, and it doesn't mean anything. You're in at least getting help. You're not out there not doing what you're supposed to do. At this point in time, even though you were in 15 times, that means you came and you asked for help 15 times, which is good. It shows that you're really trying to live your life and do something productive with your life, that you're asking for help, which is good. I know it's hard, but
it makes me seem like I'm crazy.
No, it doesn't. A person that doesn't ask for help, that goes through their life having problems and having issues, is the one that we need to be concerned about. You're in here asking for help. This is good. You want to get help. You want your life to be back on track. That's a very positive. That's really positive. And I know how hard it is every time you come in. I know you didn't want to come in today, but you're here. And that shows a lot. That shows a lot of your courage. It shows a lot that you're wanting to help yourself. That's very positive. I see it very positively. And I think it's great that you're here asking for help. I wish more people would. Okay?
Okay. Principle 7, take opportunities to utilize previously expressed information to demonstrate you are paying attention. That's kind of a mouthful, but at the heart of Principle 7 is really, again, if we think back to one of the core kind of components of good clinical interviewing, using a semi-structured interview, it's building rapport. And one of the ways that we build rapport is by using information that the client shared earlier on. So if they said that they were, for example, a mother of 2, very early on when you were talking with them, maybe even in the small talk, walking them from the waiting room to your office, when they then come, when there's a domain on the CARS comprehensive assessment called a family social domain, where they get to talk about their family structure. At that point then, when you introduce that section saying, I remember you said you had 2 kids and their names are so-and-so and so-and-so, one of the things that this allows you to do, in addition to being able to start to synthesize information and bring apparently disparate ideas together, is to remind the client that you're listening, that you're paying attention. And those things are critical to building a good relationship with somebody during a clinical interview. Mm-hmm. Pat?
That's correct. It's important to listen and to jot down, important information to children, like Matt said. And then when you bring it up later on in the assessment, you can almost see that the light go on in their face, because it's like, oh, you were really listening to me. Or when you come in at the initial and you're asking them to tell their story, and then you get to the part like about working. You get in. So I remember you telling me that you were working for a machine company for 6 years, and so you're working on machines. So, and that was full time, correct? So it shows that you were listening later on. It wasn't that you're just like, okay, let me ask the questions and check them off on a sheet, and that builds a rapport with the client. And the client thinks, wow, they really are listening to me. They were able to pick this out of everything that I was saying. I was talking about my alcohol use, but yet they heard that I worked at this company for 6 years.
Right, absolutely. And I think what's so important about that is, if you think way back in our earlier slides, that when you think about sort of the attitude that you adopt with successful clinical interviewing, expressing sincerity and having empathy, and also expressing genuine interest. I mean, genuine interest, when I think about that, it's the same thing for me when I go to my doctor. If I don't have to tell him the same thing that I told him 6 months ago, or if he looks at the notes that the nurse took on me just 5 minutes earlier even, it makes me feel like there's a continuity of care, there's a continuity of information, and that I am not just a medical record number, but a person. So it's very validating for me.
Correct,
Yeah.
correct.
So.
And we'll be showing you an example of this right now. Okay, Fred, the next section that we're going to be talking about is going to be some how your relationships are, family-wise and, social. And I noticed at the beginning of the interview when I was asking, your mom wanted to come in and you didn't want your mom in, and you said that she was interfering with your life and that. Do you want to talk a little bit more about that? Tell me a little bit more about what's going on between you and Mom.
She feels like I can't handle myself. She treats me like a kid. I'm a grown man. I have my own place. She wants to. She wants me to sign over my disability checks to her. She wants to run my life for me, and I just want her out of my life. I want her out of my life. Of my mom, but she just never lets me be, and she just hovers all the time. Mm-hmm.
Mm-hmm. Is it creating a lot of conflicts between you and her?
Yes, it is. Yes, it is. We have a lot of tense. Yeah, we fight a lot.
Mm-hmm. And how does that make you feel when you're fighting with your mom? Because you just said that you love your mom, but...
It's hard, I just want her to treat me like an adult. Mm-hmm. And she doesn't, and no matter what I say, she doesn't. She says, 'cause I can't take care of myself. Like, you never given me the chance to.
Okay.
It makes me angry.
Mm-hmm. So does that happen pretty consistently with Mom, that she's interfering in your life and you having these conflicts?
All my life.
All your life. Okay.
No.
Okay.
All my life. Yeah.
So, and you talked about fighting with her, having arguments. Are they just arguments? Have they ever become physical? Or okay.
No. They've never become physical.
Okay. How often do you argue with your mom?
Seems like every time we talk, whether it's on the phone or she stops by unannounced.
Mm-hmm. Yeah. Talk with Mom daily, pretty much?
Mm-hmm. Yeah. She calls me every day.
Okay. Then that must be hard, arguing with Mom every day, knowing how much you love her.
Yeah, she's another one that stresses me out. If I could get an apartment in a different state so I don't have a roommate and I don't have to be near my mom, that would be even better.
Okay. Well, let's take one step at a time, okay?
Yeah. Okay.
All right. Well, I want to thank you for sharing that. I know that wasn't easy, so thanks.
Yeah. Principle 8, be sensitive to trauma issues. And this is a very critical one as we become increasingly trauma-informed in our healthcare systems. I wonder if you want to speak about that, Pat.
It's very important. Sometimes clients come in and they have a very traumatized life so far, and many things have happened to them. And as they're talking to you, they're telling you all of this stuff that's hurt them, that they've been victimized. You need to acknowledge that, how hard it was for them. I, as an example, will say, that must have been a very trying time for you. It must have been very hard for you, acknowledging that, it was hard for them, and they're telling you about it. And then I always, try to say, but, you made it through it. You're a very strong person. And you're trying to bring some strengths out of the trauma, if you can, that they made it through the trauma. They're here now in your office. They're talking about it. They're getting help for whatever the issues are. And, how you need to encourage them. This was a giant first step, and you know, I'm really glad to see you here. You know, this was a lot for you, and I can see how strong you are. You know, if they have children, you know, to say, wow, I can see that you know, you love your children so much for being here after everything you've went through. You're still here. Thank you for coming. You know, I know how hard it was for you, and just show them that compassion and that empathy that you have for them.
Absolutely, and I think from what I understand in some of the conversations that you and I had, there's a very delicate balance when you ask, because the CARS comprehensive assessment does have some screening questions for trauma, but it's not something where there are a lot of questions about trauma, because really we want somebody to be able to discuss that fully with a therapist, hopefully one who specializes in treating trauma. But it's a balance, because if we ask about it, the dance is between allowing people to discuss it to the extent that they feel comfortable and not shutting them down, which could feel very invalidating, and at the same time, on the other end, not pushing people to elaborate when they don't feel like talking. And so I wonder if you could speak a little bit about kind of walking that fine line with that.
It is a fine line. There'll be some clients that don't want to talk about the trauma, and there are some really personal questions on the assessment. So when I get to that section, what usually is a good way of doing it is saying, you know, I'm going to ask some personal questions here, and you can answer them if you'd like. You don't have to answer. Remember, you always have a right to refuse to answer a question. I just want to get a sense, and I want to get a full-rounded assessment so that I be able to pass it on to your clinician. But however, if you don't want to talk about it, that's perfectly fine with me. Just let me know.
Yeah. And so giving them the option to just, if, for example, it says, have you experienced any sexual trauma, just you can say, you don't have to answer it, but if you do want to answer it, you can just choose to say yes or no. You do not have to provide any details if you so choose. But at the same time, not closing the door for them to elaborate a little bit if they want to, because again, we don't want them to feel like that experience is being invalidated because we're shutting them down.
Correct.
Yeah.
And sometimes when you have clients and you do ask questions, the sensitive questions, they will just all of a sudden start letting go of everything. So you need to be prepared for that too. You need to be prepared that if you're not, if it's not within your scope of practice to handle, make sure that they get a referral to someone. If you have a supervisor, you may need to bring a supervisor in.
Right.
Sometimes just asking the question and the person can just, they could be an hour and they're still talking because they've had so much trauma and so much victimization to them that they really need to just talk to someone right then and now. So, you know, make sure that you have a plan of bringing a supervisor in or being able to refer them out to someone.
Right. All right.
And we are going to show you an example of this right now. Okay, Fred, I'm going to talk to you, ask you some questions, and these are pretty personal questions. Remember, again, you have a right not to answer if you wish not to answer. And this is going to be with regards to trauma. And trauma can be anything from witnessing it, a natural disaster like a tornado, the basement flooding, a house fire, or anything like that. But it also includes emotional, physical, and sexual abuse. So I'm going to ask you questions within the last 30 days and then within your lifetime. Okay, so there's going to be two different answers. So in the last 30 days, have you experienced any type of trauma? Again, that's going to include, you know, any emotional, physical, or sexual abuse, or tornadoes or house fires or anything like that? Okay.
No.
How about in your lifetime?
Yeah.
Okay. What have you experienced in your lifetime? If you want to talk about it, again, you don't have to elaborate on it. I can just put, you know, yes down here, or, you know, if you'd like to talk a little bit about it so I could get the information and be able to document it and pass it on to the clinician.
When I was a kid, my dad used to beat me
Okay.
a fair amount. Sometimes with his fist and sometimes with his stick, sometimes other things. he left when I was about 10. Used to beat me pretty good.
Okay.
My mom too.
Okay. My mom too. Okay. Okay. Fred, are you okay right now? You know what? I'm going to just put this assessment aside, and I just want to talk with you a little bit. What are you thinking? What's going on right now?
Just thinking about him.
Mm-hmm. Must have been very hard for you at that time.
Yep. Sometimes all my had was Mom and I sticking together.
Mm-hmm. Mm-hmm. It's a very hard time in your life, but you came through it. I mean, you're here now. So you've lived through that trauma. Not saying that you don't need to still maybe talk to a counselor about it, but you're here now. I mean, you lived through it. That's a real strength that you have. Is you survived that. You're a survivor.
Yeah.
Not many people can say that.
Got that right.
But you are. So there's a lot of inner strength in there, in you, and a lot of courage. And look what you just said. It was you and Mom sticking together, but yet before you had told me that Mom's interfering with your life, and she drives you crazy, but yet you're sticking together with her.
We kind of got each other through that.
Mm-hmm. Mm-hmm. And yes, she has you and you had her. So don't forget your role in that too, because you played an important role in helping her through that too.
Hmm.
So there's some real strengths there that I don't know if you see, but you're a survivor. You helped your mom as a child. That's great.
I never thought about it like that.
Mm-hmm. A lot of courage in you. A lot of courage. And hold your head up high and say that, you've survived this and you did this.
Yeah. Yeah, we did make it through it.
Mm-hmm. So then I want to ask you a question. Do you want to continue with this, or would,
Yeah.
You want to continue with this? And we can reschedule it at another time if you want. Are you sure?
Yeah, I'm here.
Okay.
Let's get it done.
Okay. All right.
Okay. Principle 9, be sensitive to cultural issues. And this one, much like trauma, I think is happily becoming progressively more recognized and important part of our healthcare system. Mm-hmm. And I think that one of the things that we really want to try to do for individuals is to try to normalize the fact that there may be cultural issues which are relevant to them in their treatment. And to make it okay to say, yes, I'm an African American individual and I would prefer to receive services from an African American counselor. I think sometimes the perception is that those questions are just asked in a rote fashion, like, are cultural issues important to you? Do you want to receive services from someone of a like faith or of a like ethnicity or like gender? And I think it's important to make sure that people feel like that's very important to us as well, as the assessors and as the healthcare system, and that it's okay to say yes, and that's not going to be an inconvenience, but rather that's an important part of continuing our treatment planning and the placement process, and that as you mentioned to me when we were discussing this before, that doesn't mean we'll always be able to accommodate that off the front end because, obviously there's capacity issues and there's staffing issues and those types of things, but that it's an important thing for us to document in the clinical assessment so that we know as we're passing this down the line, we will make sure that we convey to whomever the clinical or case management organization is that we're referring this client to, that they're aware that those things are really important to the client.
Correct. It is important, and we do ask those questions because it is important to us to make let the client feel comfortable. If they're not comfortable in the treatment setting that they're in, they're not going to go. So if we can, on the front end and on the very first assessment, if we can get them to an agency that they're comfortable with and that can, have their cultural issues met, that's where they need to go. We have a provider directory. In the provider directory, it asks about cultural, and that may even include spiritual. Some clients want a faith-based program. We have that in our directory. That should be offered to the client. We need to find that out from the client. It's our job to make sure that the client gets to where they need to and where they're going to be most comfortable.
And I think it's important. I think you hit the nail on the head that when we think about culture, it's broader than race or ethnicity. We're also talking about gender. We're talking about spirituality, faith. We're talking about things like physical disabilities. So culture is much, much broader than that. And in fact, we don't have time to elaborate on all the different facets of culture here. But to be aware that when we're asking those types of questions and trying to be attentive, that there is a variety of different ways by which people perceive themselves. And it's important to try to be as attentive to and sensitive to as many of those as possible.
Correct. Correct. And we will have an example of that right now. Okay, Fred. We're moving into a different part of the assessment now, and on this part, it's concerned with regards to cultural issues. Now, culture is, it can be race, gender, spiritual, and I'd like to know how important those are to you. How important is, like, if you were to get a counselor, would you want a male or female counselor? Would you like to be in group with people of your own race or ethnicity or spiritual groups? We have some available. I'm not sure that we can, exactly match up everything that you would need, but we would definitely try at the end to match up a provider to you that would fit your needs.
In the past, when I've had therapists, I really would like a female therapist.
Okay.
I just don't feel safer around them.
Okay. And so a female therapist you would prefer to have a female therapist, so we can make sure that when we look at providers that you want to attend, because remember, you get to choose the provider, to make sure that they have a female. We can try to make sure that they have one. I'm not sure if they do, but we can try to best match you.
Yeah.
Okay.
I hope so. If it's a male therapist or a male case manager, I won't do it.
Okay, well, we can definitely check in, and if you choose an agency and we find out that there's males there, then you have an option of choosing a different agency where we can find a female for you. We can definitely try to find one to fit your needs. Okay.
Okay.
All right. No other cultural issues with regards to spirituality or anything like that?
No.
Okay.
No, I don't care. Yeah.
All right. All right. Thank you, Fred.
Principle 10, point out client strengths and look for opportunities to reinforce them during the interview. And as I hope has been clear at this point, this is a critical component of a good clinical interviewing process, that attending to client strengths, looking for opportunities to compliment them, and genuine compliments, not just, I mean, clients obviously can tell when we're blowing smoke. I mean, these really need to be heartfelt, they need to be meaningful, and they need to be, the client needs to perceive them as true about themselves, not just a therapeutic gimmick that we have. But it is so critical every step along the way. Every time we talk about a barrier that a client has, something that they're struggling with, there's an opportunity to reinforce the strengths. And that became abundantly clear to me when you and I were talking about this process, about how often you and the clinicians that you supervise are taught to do that at every opportunity. You can't do it enough, it's almost like,
Correct. It is very important throughout the whole assessment to point out the client's strengths. We want the client to leave our office with hope, inspiration, and motivation. This is what gets them to their next appointment. This is what gets them to their first appointment for treatment that they may have never been in before. Clients are scared, that they don't know what to expect. So if we can do that, give them that inspiration and motivation and hope, they will go. And it's bringing up these strengths. I mean, there have been clients that come in and they're using, they've been back to using, but there was a clean time. Ask them, so when was your clean time? What was going well for you when you were clean? What was, different? What were you doing differently? So that they can say, oh, wow, I did do this. I was clean. Because if you're clean and then you go back to using, it's almost like that clean time does not count for the client. But it really does. It's an important part of their life. And where you can go back and get some pointers on what they did. Oh, so at that time you held a job. Oh, you were more connected with your family. You were going to church. And right there's some strengths. So then you can build on that throughout the assessment.
Absolutely. And I think that, that's something that I've noticed in individuals who may have more issues that are psychiatric or mental health issues. It's oftentimes kind of interesting to me and sort of delightful in some ways when you talk to somebody who's struggling with severe depression or has schizophrenia, and they talk about a time when their symptoms weren't as severe. And what I find is that it's very rare for someone in that situation to have ever been asked, so what were you doing so well at that point in your life that caused your depression to be in remission? Usually people attribute it to medications or just some biochemical imbalance. Very rarely do they see it as something which they engaged in volitional activity that helped them to feel better, that helped them to remain in remission or to be more functional. They don't take credit for those times when things are going well. So I think it applies whether someone who has an alcohol or drug abuse problem, someone who has mental health issues, or someone who has co-occurring issues. I mean, it's just not something that they tend to give themselves credit for those positive periods in their life.
Correct, and that is true. And like I said, the more we can do that, the more we can point out as the clinicians to get that to them, the more they're going to feel motivated to go on to the next step was to get into treatment. So, and we'll show you an example of that right now. Okay, Fred, I want to talk a little bit now. You said that, during the course of your lifetime, you've been in and out of the hospital 15 times. And you thought that was really bad, but we had talked about that. So there were times where you weren't hospitalized or, and everything was going pretty well in your life. Can you tell me what was going really good at the times that you were feeling really good, and what was going on in your life?
I had my own place.
Okay.
My mom wasn't nagging me. I just wasn't so stressed out.
Wasn't so stressed out. Okay. So being stressed out is...
Yeah.
Okay.
I get stressed out, then I go to the hospital. That's always happens.
Okay. So when you have your own place and you've had apartments before?
Yeah. Yep.
And you really like being in your own place by yourself.
Yep.
You watch your own, what you wanted on TV, listen to the radio.
Yep. Live my life the way I want to. Yeah. Yep.
Okay.
Yeah.
All right. And then when, during the times that you had your own apartment, I know like you had told me before that you like to watch TV, you like to listen to music, you like to take a walk. So those are some of like your hobbies, your relaxation stuff?
Yeah. I worked at Starbucks
Okay.
too. I liked that. I liked working there.
How long did you work there?
Worked there for about 2 years.
Okay.
Just a few years ago.
Were you working full time? Okay.
No, that can't work full time. That would have messed up my disability, but
Okay.
I liked it there. People there were nice to me, and I liked seeing them every day, and the manager was nice, and I liked making people coffee drinks, and just it was exciting, and it's nice to have something to do.
Okay. Well, I commend you because I can't even keep those coffee drinks straight, what flavors to put in where, and you got that down. I don't know how you do it, but I don't even know what to order half the time with all the different flavors. And so that's great. 2 years.
Yeah.
So do you think that that's something you'd like to do again?
Yeah.
Okay.
Yeah, I would.
All right.
I would.
Well, let's see what we can get you to get everything, and then maybe that's a goal in the future you can work on with your case manager, care coordinator. Okay?
Okay.
Great.
Principle 11, use increased awareness to build motivation. Oftentimes, when people are coming to see us, I think for many individuals, this may be second or third or fourth time in treatment, but for many individuals, it may be their first time in treatment. They're oftentimes, I think, when you and I were chatting, you talked about people suddenly gaining all of this knowledge or awareness of themselves and of some of their patterns of behaviors that they never knew about before. When we think about the stages of change, pre-contemplation and contemplation, that sometimes someone who's in pre-contemplation or, let's say, early contemplation, that sometimes simply learning more about their patterns of behavior can increase motivation because it makes them aware of issues that they never realized they had before, and strengths that they never had before. But, I think that there's a real opportunity that we have here, even if we are the only treatment contact that they have, that they come in for a clinical assessment and decide they don't want anything. I mean, SBIRT is predicated on the same principle, really, So I wonder if you could speak a little more about that.
Sure. When a client comes in and they've been using, they're like, yeah, I'm using daily, I'm only, I'm not drinking that much, I'm only drinking beer. And as you're going through the assessment and you're getting all of the information, you're getting more information about the client and how often, and they were in the emergency room, and what were you in the emergency room for? Well, I was drunk and I sprained my ankle. And then you can start putting two and two together. Okay, so it was a time that you were drinking that you were in the emergency room. And they're like, oh, I never thought of that. All of my emergency room visits were when I was drinking, or I have 3 OWIs because of drinking, and now I have 5 emergency rooms. They start putting more awareness together as you're going through the assessment, and you can always bring it back in a very subtle way and say, okay, you have 3 OWIs, and then you have the 5 emergency room visits because that's at the time that you were drinking, and that would be concerning to me. I mean, you may look at it, and get some motivation. They may get some motivation out of it. Just seeing that they're able to put 2 and 2 together. And, and sometimes with them, if they're using a lot, just them getting there for that to do the assessment is a huge step. And I always tell them, this is a major step you've done. Well, I just came for the assessment. This is huge. This is the first time you've been here. This is so major. I am so proud that you were able to take this first step. I know how hard it was for you, but you took the step, and you need to, congratulate yourself for it, and make sure that they're telling themselves that it's okay. Hey, I did this. I was the one that chose to do this, so that they can build up their motivation within them. Absolutely, yeah. And I think that that sometimes when we're going through these things, that and you and I chatted about this before, but one of the keys is when you're sharing back some of this information, when you're helping them put together some of these patterns in a subtle way, you're doing so in a non-judgmental, very open, non-confrontational stance. Okay. And you gave me a great example of someone saying, I don't drink that much. I only drink, probably 3 beers a night. That's not that much. Okay, you drink 3 beers a night. Does the pattern change at all on the weekends? Well, yeah, I guess I probably have 6 to 9 on the weekends or something like that. And then having the client do the math themselves and just sort of sitting back and sort of seeing the realization come across people's faces when they start to see just how much that actually is. And you're not necessarily telling them to change that behavior. You're not judging them for that behavior. But sometimes the simple process of increasing awareness can have a dramatic impact on individuals. And I was sharing with you this one particular study that I read several years ago where they were looking at a group of women with substance use disorders, and they assessed them several months before beginning treatment, and then they assessed them again right before they began treatment, and a significant chunk of the women had reduced their alcohol and drug use just by having, and there was no other treatment that had been provided in the interim. So sometimes just having that increased awareness, and again, like we talked about before, that SBIRT is based on the same kinds of principles, that increased awareness and some brief feedback can be enough to change some people's risky drinking behavior. And so it's the same type of principle. But I think I think it's very valuable and an opportunity that we have to make a difference for individuals, even for those individuals who come once, see us, and then don't return for services. At least we've been able to do something for them. Correct. And we'll show you an example of that right now.
Okay, Fred. I just want to go back to something you had said earlier, and it was way earlier. It was at the beginning of the assessment. You talked about you like to watch TV, listen to music, walk, and have a couple beers. Can you tell me about the couple beers? And how often does that happen? That you have a couple beers?
I don't know. It's just a couple beers. It's I don't know, at least a few times a week.
Okay. And just so that I get the right number, a couple means how many?
2 to 4.
2 to 4.
Just out of my roommate's, he's got a drinking problem, as I said. He's always got a 6-pack of, a case of Miller Lite in the fridge. I don't know, I have 3 or 4 of those every night, I guess.
Okay. 3 to 4 every night?
Yeah.
Okay. Okay, so that's 3 to 4 every night. Is there any time where you would drink more beer? Like on weekends or?
Yeah, I mean, he works during the day, got a job part-time job, quad graphics during the day, and on the weekends he and I, we watch a lot of ESPN, and I guess we drink more then on the weekends.
Okay, how much would you say you drink on the weekends? Is this all day? Is it only, like in the afternoon or at night?
I don't know, he starts in right around like 8 or 9 in the morning on the weekends.
And what time do you usually start?
I'm not an alcoholic.
I'm not saying you are. I just want to know about what time you start drinking on the weekends.
I don't know, probably noon.
Okay. And how many do you think you have on Saturday? How many beers would you say?
It's tough to say because I guess more than the weeknights, I guess, because we go through case.
Okay, and a case is 24.
So probably...
So about half, maybe? More than 10?
No, maybe 8.
Maybe 8. Okay, so 8 on Saturday and
Sunday.
And on Sunday. Okay.
At least, yeah.
So
unless the Packers are on, then it's even more, I guess. But 8's probably what it usually is.
So weekdays, then every weekday it's 3 to 4, and on Saturdays it's 8, and on Sundays it's 8. Do I have that correct?
Yeah, I guess so. But you know, I can hold my liquor. I mean, it's not.
Okay.
I don't feel it. I don't drive. I don't do anything like that. I mean, I can hold my alcohol better than most of my friends.
Okay.
It's more than I thought.
I'm sorry?
It's more than I thought.
It's more than you thought. The total number of drinks, it's more than you thought, or
Yeah.
does that concern you?
Maybe a little, I guess.
Okay.
I'm not here for drug and alcohol counseling, though.
Right. I know. You know, but if this does bother you, I mean, you know, we can always incorporate that into, you know, some of the recommendations. You know, this is a huge step that you're coming and you're talking about this, and to me, it seemed like once you started adding these up, that you were concerned with, you know, your body language, that you were showing me you were a little concerned on how you know, many of these beers you were drinking.
Yeah, maybe a little.
You know, I don't know the total of them. I'm not in math, so.
Yeah.
But you know, if you're concerned with that, maybe that's something that we do. I mean, you're here. Let's get it all done at once. It's totally up to you. But I think, you know, that you noticing it is a good start. It's a good start.
I'll think about it.
Okay, that'll be great.
Okay.
And you can let me know. And even if you don't want to do anything today, you can always tell your care manager or case manager later on that you want to do something about it. Okay? That option's always there for you.
Okay.
Okay?
Okay. Principle 12, redirecting the talkative client, engaging the withdrawn client. And obviously there are many, many variants on the clinical presentations that you might see, but I know that you've probably seen them all, Pat, so I wonder if you could speak a little bit about that.
Correct. Sometimes we have clients come in that are very, very talkative, and they want to tell us their life story from age 5 on up every year. And I mean, that is important information to have. And we do listen, and we listen and try to pick out what we need. But there comes a time when you need to just really stop the client, but you have to do it in a very non-judgmental, soft way of doing it. Mm-hmm. And what we usually do is that we will tell let them take a natural break, because they will naturally take a break in their talking, and saying, you know, this information that you're telling me, I want to thank you for telling me all of this. I know how hard it is for you to elaborate on all of this stuff that's went on in your life, and it's very important information. And this is the exact kind of information that you need to tell your clinician when you meet with them. I will put it down in the notes. I will make sure that the clinician gets a heads up on it, but this is exactly what you need to be talking to your clinician about. And then that's a natural break at that point that you can go on to the next question or the next conversation you want to have.
Right, absolutely. And I think the point that you made about making sure that they're aware that it's not like you're saying, whoa, this is too much, make sure you tell this to your clinician, and then you don't write any of it down, that you are going to write it down, that you're going to make sure that that information did not fall on deaf ears, and that you're going to pass that on to them. Because again, I think much like bringing up the principle that we had earlier, where you try to take opportunities to bring up information the client previously shared, we want to make sure that they feel listened to, that they feel validated, that all the information that they share is important because they're important, but kind of redirecting it back towards the most appropriate channel for that.
Correct.
Yeah. So I'm wondering if you could also talk a little bit about working with the client who's disengaged, who appears to be withdrawn.
There comes times when clients will be in the assessment, and then right in the middle of it, they will shut down, literally just stop talking, head down, not paying attention to anything. At that point in time, you really need to just put the assessment aside, put the paperwork aside, put everything aside, and just what I do is I ask the client, how are you feeling? Are you okay? What's going on? What are you thinking about right now? Let's just talk. Forget the assessment. Let's just talk. And it might be that the client is experiencing a flashback from some trauma. The client may be thinking about, something with the family. They could be thinking about anything, but you need to stop the assessment at that point if they're withdrawn and try to engage them in just talking about whatever they're feeling or thinking about. That will bring them back to the here and now and back to the assessment.
Right. And I think it also, again, it's another opportunity for us. It's these clinical nuggets that you and I talked about before. It's an opportunity for us to remind them that although this is a semi-structured clinical interview and there's a purpose to it, the main purpose is to help the client, to let them know that we care about them, value them as a person. We want to get them what they need. And if what they need right at that moment is to not have the interview and to just be able to have a conversation with the person sitting across from them because that's where they're at, that's what we're giving them. And I think all of these are wonderful tools, not tools, I don't mean to make it crass, but they're wonderful ways to build rapport with the client, to make sure that they know that we care about them. Yeah.
And we'll show you an example of this.
Okay, Fred, I want to go back to a little bit what you said, why you came in, that you were referred here from PCS. Your doctor told you that you needed to come in for more of assessment. Can you explain a little bit about that?
Not really. I mean, I don't think he knows what he's talking about. I just need an apartment. I mean, it's not, I'm not sure.
Okay. Why were you at PCS?
My roommate stressed me out. Suddenly the cops are there. I don't know who called them. Probably my mom.
Okay.
May have been my roommate.
So the police were called. What was going on that the police were called?
I don't even know.
Okay.
I had a beer or two.
Okay, so you were drinking. You had a couple beers.
And then I don't even remember what happened. They said that I took my roommate's Xanax.
Okay. How many did you take?
Whole bottle.
A whole bottle? Okay.
I don't know how many.
Okay. Fred, I'm going to ask you a difficult question here, and I just need for you to answer it. Was that a suicide attempt?
I don't know. Maybe.
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 Okay. Okay. Fred, how are you doing right now?
Not that good.
Not that good. Okay. Are you having thoughts of suicide again?
Just no.
No.
Just thinking about that night?
Okay, what are you thinking about that night? So I need to be perfectly clear in this, Fred. You are not having any thoughts about hurting yourself right now. No. Okay. Okay. But that night still bothers you quite a bit. Okay. Do you want to take a break? Do you want, take a breather and then come back and finish the assessment, or would you like to reschedule it, or what would you like to do here, Fred? It's totally up to you. I want to make sure that you're okay.
Take a little break.
Take a little break? Okay. Do you want to go, and just take a walk outside for a second?
Have a smoke.
You want to have a cigarette and then come back in? Okay. You going to be okay? Do you want someone to go with you? You want to go by yourself?
No.
You're okay?
Oh, can you make sure my mom's not in the waiting room?
I will definitely go and check and make sure she's not there.
Okay.
Okay, and if she is, we'll figure out some way to get you a little break without her seeing you, okay?
Okay.
Okay.
I don't want her to see me.
Okay.
Just make her worried.
Okay. But you're okay, all right? You're going to be okay?
Yeah.
Okay.
Yeah.
Okay, good. All right. I'll go find out if Mom's in the waiting area.
So in Principle 12, we also want to talk a little bit about working with the client in severe distress. And Pat, I wonder if you want to say anything about that.
Some clients come in and they're in major distress with regards to many different situations. At that point, you need to bring the client in. It may not even be the right time to do the assessment. It may be a time where you need to just sit and talk with the client. Maybe you can bring their distress level down a little. If not, you may need to, can I call a family member? Can I call someone to come and get you? A client may want to be there to do the assessment, but if they're in such distress that they are such on heightened, I don't know what you call it, heightened body language, heightened agitation in that, and that you cannot do the assessment, it's better to just talk to them and try to get their level down and then reschedule the assessment for them.
Yep. And with working with clients experiencing psychosis, obviously most of you are aware there are a variety of presentations, and it depends on what the presentation is. If it's someone who's experiencing a number of negative symptoms of schizophrenia, obviously you are attempting to talk to them and engage them to the extent that you can. But, and we'll talk about this later at another principle, it may be that you need to stop the interview. And that's why contacting or giving permission or obtaining permission to contact collaterals that we talked about very early on during the informed consent confidentiality process is so critical, because we have individuals who may not be able to share a lot of information or may not want to share a lot of information if they're really paranoid. And that's okay. That's okay. We want to try to make them feel as safe as possible, whether that means letting them elaborate very little and then moving on, whether that means stopping the interview entirely, or whether that means, just, again, calling an end to the interview and saying that, okay, that's fine. And then what you would do then when you are actually going through the process of the filling out the answers, there would be things like either you would leave it blank and you would try to come back to it later, or you might say client declined to respond, and that's okay too. We don't want to push somebody who is in a severe psychotic state, who is not ready for this. And then what we also really want to be thinking about in that situation is not continuing the interview at all, but we want to think about how do we then respond to make sure that we keep them safe, for example, or do they need to go to PCS? Do I need to call in my supervisor and call a mobile clinician? Because that might be an individual who hopefully that individual will be caught at the front door and won't necessarily make it back that far. But if someone starts to decompensate there, we need to think about the immediate crisis response. But then you're also going to have individuals who are presenting who are very cognitively disorganized. And in those situations, letting them talk, redirecting them, as Pat mentioned earlier, I think is important too. But you also have to remember that you're qualifying everything that the client is saying if it becomes clear to you that they may not be the best historian. And again, we're falling back on collaterals in that situation, because we want to try to write it down in the client's words, whatever the client is saying, as much as possible. But we also want to be cognizant of the fact that the information that we're getting may be impacted by a variety of things, including poor memory, including thought intrusions, a variety of other sort of psychotic symptoms that may be influencing and make them poor historians.
Mm-hmm. Matt, I have a prime example of that. Mm-hmm. We had a client in with one of our clinicians, and he was diagnosed with paranoid schizophrenia, and he really wanted to do this assessment. But about every 15 to 20 minutes, he needed to get up and leave and go to the men's room and just stand in there to recompose himself, to be able to bring his breathing back down, everything. And then he came back in and did another 20 minutes of the assessment, left again, and our clinician would just walk him to the front door, let him do what he needed to do, and then bring him back in. And it worked out really well. He was able to get through the whole assessment and get the help that he needed.
Absolutely. And I think we're going to talk about this in Principle 13, but it's things like that that make our mental status examination, which you are still doing the entire interview, so critical. Because just because they're not giving you the information that you're asking for in the interview does not mean they're not giving you information. And we may not be able to get, there's certainly going to be some clients where we're going to get minimal information based on the semi-structured clinical interview questions, but we're still getting very sort of rich clinical data about what that individual is struggling with. And certainly in that situation, even if the client wasn't able to finish the interview, we would know that that individual needed services, even if we didn't necessarily have all the specific
Correct.
data points to provide to complete the assessment.
Correct.
So.
Correct. Okay. Next slide.
Principle 13. Noting nonverbal behaviors and mental status during the interview. We talked about this before, just in the previous slide, that these are things that you are examining the entire time that you are in your interview. You are looking at things like body language. Are they reserved? Are they withdrawn? Are they agitated? Is their speech pressured? Is it slow? Is there evidence of psychomotor retardation or excitation? What is the tone of their voice? What is the rate, the pitch? All of these things. You're looking at vocabulary, fund of information, things like that give you an estimate of IQ. All of these pieces of information you're picking up on as just a human being. We all are attentive to these things just in normal human interactions. We know those things. We know when something is off. We are attentive to it. And those are things that in a good clinical interview, even a semi-structured interview, you are paying attention to, because you want to not just note it as one human being interacting with another, but as one human being who now sees that as a form of data. And I don't mean that people should get reduced to data, but those are important things to convey in the comprehensive assessment, summary, and write-up. The things that you note about the client's presentation, things that you become aware of very subtly, that start from when you first go to the front to the waiting room to bring somebody back to your office. I wonder if you wanted to speak about that a little bit, Pat.
It is you know, when you greet the client, you need to start noticing their nonverbals. And like Matt had says, sometimes you have eye contact, sometimes you don't. It doesn't mean that when you don't have eye contact that they're not telling you the truth. It may be something within their culture. It may be that they're embarrassed that they have to come and tell you this, that they're asking for help. There's many different reasons. And Matt spoke a lot about watching for the client, but you also need to watch your own body language as a clinician. I have seen clinicians in my time where a client's talking and they roll their eyes. What is that telling the client? Or they'll be they'll be writing and all of a sudden they'll put the pen down and, you know, like, okay, and when are you going to get done with this so I can really get what I need? You also have to watch your own body language. If you're like in the old where you lay back, whatever, that's an I don't give a care attitude for what I see. You always have to watch your body language because the client is watching you. They're taking cues from you. If you're shutting down to what they're telling you, they're going to shut down. Next slide, please.
Next slide. Meet the client where she or he is at. Now, we have this as the last principle, but really this principle, and any of these principles, they're in order for the sake of a sequential PowerPoint presentation, but they don't need to be and shouldn't be applied in sequence. This should apply regardless of where you're at in the clinical interview, whether it's going to get somebody in the waiting room, bringing them back to your room during the interview, at the end of the interview. It's very important that we try to be attentive to the client's immediate needs. And I wonder if you could speak more about that, Pat.
Correct. We need to, even though we're there and we're trying to get the assessment and the client wants to come in and do the assessment, sometimes they need to have their basic needs met first. There may be a client that's been homeless, that's been on the streets, that's been using or with mental health, and they're coming in and they haven't eaten for days. I mean, at that point, you need to assess if their basic needs are being met. If this client is hungry and hasn't eaten for days, how can you have that client sit in there and do the assessment? What you need to do is you need to find them appropriate resources to meet their basic needs with getting them a food pantry, finding them someplace where they can go and get a hot meal, and then rescheduling the assessment to come back. If you get their basic needs met, more than likely they are going to come back for that assessment because the client understands that you care about them. Not just a number, let me get you in, get you out, but you care about them. You took the time to help them find food or clothing or a shelter or anything like that.
Absolutely. And the client's state at the beginning of the interview can have a profound influence on the types of information that they provide, whether it's quality information, and has a profound influence on the mental status exam that you're doing during the interview. So I agree with you, and it's critical to make sure that they know that we care about them. And it also, I think, helps to build trust. They trust that they can come to us to get what they need. And if we can get them what they need immediately, and part of that might be, as you said, saying, well, let's get you something to eat right now. Let's not start the interview. It also might be during the middle of the interview being able to say, look, you know, it seems like you're really fatigued right now. And that's something else that our individuals who are struggling with mental health disorders will often struggle with. Is fatigue. An interview like this might be a lot for them to sit through at one time, and that's okay. You know, the comprehensive assessment is not bound by time or location, and that's something I think is very important to emphasize. That yes, I mean it would be ideal if you could get it all done in one fell swoop, because the faster you get it done, the sooner we place people into services. But if somebody does it one day, and after 45 minutes, they're really wiped out. They don't feel, you can see that you're losing them. They're becoming disengaged. It's okay to say, hey, do you need to take a break? And if that's not enough, do you want to reschedule for tomorrow or the next day? What would work best for you?
Correct.
Meeting them where they're at means not just meeting them where they're at in terms of what they need from a basic need standpoint, but also meeting them where they're at in terms of their ability to complete the interview. And if we do that, if we make that okay, as you mentioned, the likelihood that they'll return is increased, you know, because they'll know, as you said, that they're not just a number, that this isn't just something that we have to get through, but that we are attendant to their needs first.
Correct. I agree.
Yeah. So, that concludes our presentation. Thank you for watching.
Thank you.